Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today, in our conversation with expert series, I have Dr. Gaurav Prakash, who is professor in clinical hematology and medical oncology at one of the premier Indian institutes, the PGI Chandigarh, here today to talk to us about understanding T-cell non-Hodgkin's lymphoma, providing an Indian perspective. Welcome, Gaurav.
Thank you, Dr. Vish, and I'm really happy to be here in the conversation with you.
So, for our audience, can you give some context about what is T-cell non-Hodgkin's lymphoma and its how big a problem it is?
Yeah, so T-cell non-Hodgkin lymphoma is a very exciting area. We know we have two kinds of white blood cell, lymphocyte to be precise, T and B cell, they're just name of these cells. And the tumor which originates from these T cells is called T non-Hodgkin lymphoma. And luckily, these tumors are not very common because whenever they occur, they are usually very aggressive and difficult to treat tumors. If we can go to the next slide. Yeah.
Yeah. So, how do
So
you kind of clinically divide them?
Yeah, so T cell actually, if you see the latest classification, there are more than 30 types of T cell lymphoma. And I'm a clinician. And if you have a look at this from a clinician's point of view, you can have a two broad group. Number one, T cell lymphoma, which involves skin or cutaneous T cell lymphoma. Some of the examples are listed on the slide, like cutaneous T cell lymphoma, cutaneous ALCL, lymphomatoid papulosis. On the other hand, the T cell lymphoma, which involves either the lymph node or internal organ, they are systemic T cell lymphoma, fairly more common and more aggressive too. So you can see some example like PTCL, peripheral T cell lymphoma, ALCL, there are some complex names. And as we go ahead in the discussion, we will discuss them more.
So, how common is it in India? You said it's overall not very common, but give it an
Yeah.
Indian flavor.
Yeah. So T-cell lymphoma globally is not a very common lymphoma. And in India, the incidence of T-cell lymphoma is falling somewhere in between what we see in the Western countries, mainly North America, and the Far Eastern countries. If to just to give you some figures, if you take a look at the next table, so yeah, this one, yeah, please click twice. Yeah.
Okay, there goes.
Yes. So here you can have a look that T-cell lymphoma, this is a data from New Delhi, and the patient pool in New Delhi AIMS is mainly represent Northern India. In this series, which is fairly large, more than 4,000 patients were there, but the proportion of patients who had T-cell lymphoma was only 16%. If you see globally, in the Western countries, North America, the incidence of T-cell lymphoma is around 5 to 10% only. But if you go to the Eastern countries like Hong Kong, Taiwan, there the proportion of T-cell lymphoma is relatively higher, and around 20% of the patients of all lymphoma would have T-cell lymphoma. This data particularly shows some difference. This is published from New Delhi, and you can see that the commonest subtype also differ. In India, the most common subtype is PTCL. The second most common subtype is anaplastic large cell lymphoma. On the other hand, in the Western countries, this is a fifth most common. So there is some difference in the presentation as well as incidence of T-cell lymphoma between various geographical locations.
So, how do patients present?
Yeah, so there is not much difference between presentation of a T or B cell lymphoma. The commonest presentation of lymphoma is enlargement of node here and there. One particular point I would like to mention that the number of extra nodal site involvement in a T cell lymphoma is slightly more. So a treating doctor has to be sharp to consider a possibility of a T-cell lymphoma whenever there is an atypical extranodal organ involvement, for example, lung, GIT, or spleen, or nasal cavity. These are the sites where some unique T-cell lymphoma may present. Apart from this, T-cell lymphoma slightly have more B symptoms. So B symptoms are actually nothing but constellation of simple symptoms like fever, weight loss, and night sweats. So if somebody is presenting with a nodal swelling with these kind of symptoms, one should keep a possibility of a lymphoma. And if they have more atypical features, then you can suspect T-cell lymphoma, but it is the job of a pathologist to tell us. Clinically, we should be refraining from diagnosing B and T-cell lymphoma. It is a job of a pathologist. We should suspect it and then proceed with a biopsy or other investigations.
So I guess partly the presentation depends on the site of involvement.
Yeah. So as you have shown in the slide very nicely, clinically, while pathologically T-cell lymphoma is more on the basis of type of T cells, their immunohistochemical features, but for clinicians like me, it is the syndromal presentation. Site of involvement is very important, like cutaneous T-cell lymphoma. They are fairly common. The good thing is that most of them are very slow growing indolent lymphoma. And many of us have heard about mycosis fungoides, which is the commonest kind of T-cell cutaneous lymphoma, very slow growing, sometimes does not even require treatment. But if you see on the left side of this table, the involvement of nasal cavity, upper aerodigestive tract, liver and spleen, and lymph nodes. These are the one which are more aggressive, usually more aggressive. They grow very rapidly. And the most difficult part of these tumor is they have high level of drug resistance. So if you start chemotherapy, while many of them will respond, but very soon they will develop drug resistance. So that is the biggest challenge that we have with these tumors.
So how do you diagnose a T-cell lymphoma?
Yeah, so as I said in the beginning, a high index of suspicion is very important. Lymphomas, I'll say they're very surreptitious. They will creep in very quietly, and there are not very clear-cut signs that this can be a lymphoma. For example, a breast cancer person, a lady may present with a clear tumor, and she will report to you that, Doc, I have a tumor in my breast. Such things happen less commonly in lymphoma. Sometimes they will just present with B symptoms. If GI involvement is there, it can be just malabsorption and diarrhea. In nasal involvement, they can just present with bleeding through nose or nasal blockade. So the manifestations are very protean, and it depends on the type and site of involvement. But we should keep in mind, in general rule, if you are having any atypical growth or nodal enlargement anywhere in the body, along with some B symptoms, one must suspect possibility of a lymphoma.
So what are the kind of tests that are done to nail the
Yeah.
diagnosis?
Yeah. So here I would presume that initial general test, for example, complete blood count, kidney and liver function tests are a routine part of examination. The initial most important imaging is a PET-CT. And in centers where a PET-CT scan is not available, a good quality contrast enhanced CT scan of neck, thorax, and abdomen is required. Having done that, one should look for the site of biopsy according to the most commonly involved area, varies from lymphoma to lymphoma and person to person. So after you have done the biopsy, you have a tissue which a pathologist will tell you whether it is a lymphoma or not, and if lymphoma, then what type of lymphoma is there. For T-cell lymphoma, we have some particular tests. Like if we remember our training in pathology, we were told about T-cell receptors, B-cell receptors. So sometimes doing a T-cell receptor study is important because it can distinguish between types of lymphoma as well as a lymphomatous versus non-lymphomatous process. Um, the only limitation is that in majority of the countries out of academic institutions, access to T-cell receptor testing is not easily available. So therefore, a pathologist would rely on morphological features of a tumor and immunohistochemistry, which is like CD markers. So these are some initial tests. Now, apart from that, we have some specific tests. As I told you in the beginning that in the eastern part of the world, T-cell lymphoma is more common. And the epidemiologists have studied and found that there is a higher incidence of Epstein-Barr virus and HTLV virus. And those viruses predispose an individual for this kind of lymphoma and also contribute in oncogenesis. So therefore, for certain lymphoma like NK T cell lymphoma, EBV testing is recommended, and it is done by EBV in situ hybridization technique. So if the patient is having EBV ISH positive, the diagnostic probability of NK T cell lymphoma increases. Some tumors at some centers, we also do a copy number testing for EBV, but by and large, it is not used for treatment decision. Now, one peculiar point, especially if medical students are listening to this podcast, is that some of the T cell lymphomas are associated with a unique syndrome, which is HLH, hemolymphocytic hemophagocytosis. And we all know that if you do ferritin triglyceride in a patient with cytopenia, you can diagnose HLH. The lymphomas or T-cell lymphoma, which are known to be associated with this are AITL and NK T-cell lymphoma. So these are some specific tests which, we often think of and do in patients who are suffering from various kinds of T-cell lymphoma.
So how do you approach it once the diagnosis is made? How do you formulate a treatment plan?
Right. So by now we have seen that how a patient would present. A biopsy is almost always required. And we also need a cross-sectional imaging in the form of a PET-CT or a CCT scan. Once you have completed this task, we clearly know what is the stage of the disease and what is the histological subtype of lymphoma. Which type of, because as I told you, T lymphomas are around 30, 35 different types. So if a patient is having aggressive lymphoma, especially which is growing rapidly, having multiple sites of involvement, is advanced stage 3 or 4, these patients would need immediate treatment. At the same time, some T-cell lymphoma can be really indolent or slow. For example, cutaneous lymphoma. And say if cutaneous lymphoma is involving less than 10% of the body surface area, then the only thing it will need is a topical cream, maybe topical steroid or a very small mild kind of therapy. So therefore, I would now restrict my discussion to a systemic T-cell lymphoma, which would require a systemic chemotherapy or a combination of chemo or immunotherapy. As all of us who work in the field of hemo-oncology, we understand that CHOP is the backbone. In 1974, the first paper was published when CHOP came into use, and probably half a century later, this is still the backbone of most of the lymphoma, especially T-cell lymphoma. If you see carefully in this slide, various kind of systemic T-cell lymphoma like PTCL, ALCL, EATL, which is enteropathy-associated T-cell lymphoma. This is hepatosplenic T-cell lymphoma, and then extranodal NK T-cell lymphoma. You can see the first row of these blocks. In most of them, the main backbone of therapy is CHOP-based chemotherapy. One honorable mention is use of etoposide. Now, etoposide is a topoisomerase 2 inhibitor, and it has particular activity, and it enhances the efficacy of CHOP therapy if added, especially in patients who are having ALK positive ALCL. So you can see the second block here, ALK positive ALCL, the addition of etoposide gives maximum benefit. Those who are seeing this slide, they can very well see that CHOP plus etoposide, whether in every 14 days or 21 days, makes the backbone in different combinations. One clear difference is NK T-cell lymphoma. Now, NK T-cell lymphoma is a unique disease, involves nose and paranasal sinuses. There's a palatal perforation, sometimes goes to orbit. I have seen patients who have become blind because of late presentation. By and large, it is locally invasive disease rather than metastasizing. So therefore, the treatment focus involves radiation and chemotherapy both. If it is only stage 1 and 2, we only radiate with some support of chemotherapy. But if it is advanced stage nasal lymphoma, then chemotherapy is the primary way to treat, and also substantiated by the radiation. So this is a unique disease treated differently. These tumors also do not respond to anthracyclines like doxorubicin because they have PG140, which leads to resistance against anthracycline. So therefore, in these protocol, we do not use. Like our CHOP H is anthracycline. It is not used in this particular type. That's a unique point. In all other subtypes, it is CHOP plus etoposide in various, combination and doses. Now, once we have given 4 to 6 cycles, we assess whether the patient is in CR or partial response. And after that, there is a role of doing a stem cell transplant. In most of the cases, it is autologous stem cell transplant in first remission. Is honorable mentions are extranodal NK T cell lymphoma, patient with EATL, and patient with PTCL. It is all clear, there is no doubt. If you have a patient who is in complete remission after initial therapy and the patient is fit enough, you consolidate your remission with an autotransplant. The only condition where autotransplant is not needed in T-cell lymphoma is ALK positive ALCL, where if the patient after 6 cycles of chemotherapy is in CR, we observe. So this is in a nutshell how we treat various systemic T-cell lymphoma. Again, I will in 2 or 3 lines. CHOP is the backbone. Etoposide is a very good addition, especially for ALK positive ALCL. After you have treated these patients, in most subtype, you have to do an autologous transplant, almost on the lines of multiple myeloma, we can say, except for patient with ALK positive ALCL who do not need autologous transplant in first remission.
What about modern drugs like brentuximab vedotin?
Yeah, yeah. Thank you for bringing this up, Dr. Vij. The people who were treating these tumors, they had a complaint to make because a B cell community is rich. They got initially rituximab, then they got obinutuzumab, now polatuzumab, and nothing much happened in the domain of T cell lymphoma. But of late, we have got BV, which is brentuximab vedotin, which is almost like a monoclonal antibody, but this is antibody drug conjugate. So there is an antibody, and at the back of antibody, there is a chemotherapy, riding on the back of this chemo. Here it is vedotin, or the scientific name is monomethyl auristatin E. This chemical is highly cytotoxic. So when you give this drug, the monoclonal antibody hunts for CD30. It goes and binds CD30. The whole complex is internalized, and then the drug is detached from the antibody and kills the tumor and the surrounding cells. Really, it's sci-fi when it came first, the antibody drug conjugate. This is the first ADC get approved for this indication. And now, luckily, when we used it in most of the subsite or condition of PTCL, there was benefit, but the maximum benefit again was seen for patient with anaplastic large cell lymphoma. So, Dr. Vij, if you see with this discussion, we can see that maximum benefit of etoposide, maximum benefit of brentuximab, maximum benefit of intensification. There is a bias towards ALCL. So I think biologically ALCL is more forgiving than PTCL, NOS, and other types like NK T cell lymphoma. So therefore, here also, brentuximab vedotin has maximum benefit for patients suffering from ALCL, while there is benefit in other subtypes also, but then we still have to wait for more or better drugs to improve outcome of patient with PTCL NOS.
So let's talk a little bit about what are some of the challenges that you face on the ground in the Indian context. Uh, Obviously, a lot of the data gets produced in Western, more affluent countries, and the realities on the ground in the developing world are often different. So could you give us a little flavor for what you see are the challenges?
Most certainly. So the biggest challenge we are finding while we practice hem-oncology, especially lymphoma service, is that there is a lack of awareness and understanding in the periphery about possibilities of a T-cell lymphoma or various types of T-cell lymphoma. I will share my experience from my clinic that when I receive patient from peripheral areas, at max they walk in with only one report of atypical lymphocyte seen. At one point we are talking about brentuximab vedotin and molecular testing, T-cell receptor, alpha, beta, gamma, delta. So the biggest challenge that we face is lack of awareness and understanding of these malignancies, which may have a very, very protean manifestations. So if we have, say, for example, a basic diagnosis elsewhere and basic workup already done, the time spent with us before starting treatment will shorten. So that is part one. The second challenge is it is so heterogeneous. Now, for example, a T cell lymphoma who has GI T cell lymphoma would usually go to a gastroenterologist. A patient with NKT cell lymphoma will go to the ENT service. Similarly, cutaneous lymphoma will go to dermatology. So therefore, it creates confusion, delay in referral. So while I encourage, creation of awareness in the community, it is also required that we train our fellows, our practitioner in other specialties about these possibilities. Because say in CTCL, for years I have seen patients who are treated with eczema. This is eczema, they give some steroid and lymphoma would improve. And ultimately they will present in a leukemic phase very late. So the two biggest challenges, delayed presentation in India and a relative lack of awareness in other experts, other in the field of medicine regarding these possibilities. The other part is we are really short on data. If you see, I showed you one paper from AIMS, but that is not a T-cell lymphoma data. They just gave a spectrum of various lymphomas and they stopped there. Really, what are the clinical manifestation of T-cell lymphoma in India? What are the treatment outcomes is something I think we need to come together and work on this. So as you have already mentioned that the data on Indian T-cell lymphoma is really sparse, and some of the groups I am working with are working on this project. Maybe in a year or two, you will see some good quality data on this. As you see, at present, there is no registry which is systematically keeping the T-cell data. But now efforts have just started, and maybe in coming 2 or 3 years, we will have a more systematic and multi-center data, which will give a true picture of at the national level. So these are the few challenges that we have. And the third challenge that we have is access to drugs. Now, if you see T-cell lymphoma in the Western countries, the drugs like HDAC inhibitor, romidepsin, uh, hypomethylating agents, some of the newer ones, alemtuzumab, brentuximab. So they are much easily available. Now, brentuximab has been launched in India last 1 year. It is available, but it is not accessible because let me be the advocate of our patients. The cost is prohibitive. And if you see from the Western perspective, if I tell you the cost, you will say it is very, very affordable. But when we see a general patient who is going to buy brentuximab, it is going to be really, really difficult. And as a doctor, as a hem-onc person, what pains me that you have a drug and it is not accessible. Sometimes, you don't have a drug, it is okay, we accept it. So the challenge is the cost of therapy also, and some kind of advocacy or discussion is required in India to bring down the cost of modern drugs because some of them are really efficacious.
Yeah, I think even in the United States, I think the cost of these drugs is often prohibitive if you don't have insurance. This is something that certainly nobody, even in the West, can afford out of pocket. So I totally empathize with you regarding the dilemma of accessibility and affordability. So what do you think is the path forward?
So I think, as I said in the previous part of my discussion, is one path is that we educate more medical specialists about possibility of T-cell lymphoma. And I think webinars like this and much more focused webinars addressing involving other experts in other fields. And we talk about possibility of these atypical lymphomas arising at atypical sites. By doing so, we may reduce the time to diagnosis and then from time to treatment from diagnosis. Both can be reduced and both are pivotal in improving outcome of our patients, even with basic drugs. So that is one challenge that we have. The second challenge is that we, the majority of the research comes from say North America, where a large proportion of patient is Caucasian or maybe some part is African in origin, which may not truly represent biologically Indian population. So therefore, India-centric data, which types of lymphoma, of T-cell lymphoma is more common, what is the true impact of modern treatment or etoposide, whether it works in India or not. So some kind of niche to begin with retrospective analysis of whatever we have done, and then a systematic, carefully planned trials which can answer local questions are required in this field and for that matter in any field of medicine. So I see a path forward that people who are interested in the field of lymphoma, they come together. Because of the rarity of this disease and scarcity of time, majority of the clinical trials or thesis I see PhD research is on B-cell lymphoma because it is easy to get patients for B-cell lymphoma. It is easy to get tissue. So there is a natural tilt towards researching and working with B-cell lymphoma. There are 8 to 9 drugs specific to B-cell lymphoma which are available in India. For T-cell lymphoma, we have only one brentuximab, and all other drugs are conventional chemotherapy. So these are the 2 or 3 points: creating more awareness in the healthcare provider among community practitioners, doing more India-specific research, and answering local question. So I think as a individual center, it will be very difficult to do the research because of the rarity of the tumor. What we need is a consortium. Like in the US, we have Alliance, SOG, we have German group on very active in lymphoma, Nordic group. Similarly, we need to have some Indian group which is coming together and focusing this very peculiar problem and answer the question more specific to India and other developing countries.
What about the access to stem cell transplantation? Is it now better than it was in years past? And what are the success rates? Are the morbidity and mortality of transplant something in India that is now at par with what is worldwide felt to be less than 1%?
Right. So that is a good point, actually. One thing which I think has increased significantly in India is access to stem cell transplant. We have Indian Society of Bone Marrow Transplant, and they have some data. They collect data, and they have shown that number of transplant is increasing exponentially, and and the number of centers offering transplant has also increased. So, and the most important point I would like to reiterate here, the average cost of doing an autologous transplant in India is somewhere around 10,000 US dollar. I'm just converting them to the US dollar terms, one autologous transplant. Now, the survival advantage in various studies is up to 15 to 20% overall survival, which is a big number. If I translate the same to the cost of brentuximab vedotin, then $10,000 will be used in 3 or 4 cycles, 3 or 4 months of brentuximab vedotin therapy, which is actually only half of the full treatment. So therefore, I think for us, while it is good to have BV or etc. with us, but then the emphasis should be more on stem cell transplant. This is a proven therapy, effective therapy, and if we see the cost benefit ratio in Indian setting, it is much in favor of doing an autologous transplant. You asked one more question regarding success rate. Yeah. So autologous transplant, by far, the centers which have been doing transplant for 4 to 5 years, now they have mastered the art of doing this transplant. The TRM, I will say, is not still below 1% because apart from the expertise, there is some incidence of global infection, latent tuberculosis, patient-related factors which are not modifiable. So therefore, still TRM remains high, but higher than what we see in North America. But the number is very has improved tremendously. From earlier, it used to be 6 to 8%. Now I can say we are safely below 3% TRM with autologous transplant, which, given the circumstances and situation, is a good achievement.
So, at risk for repetition, could you just tell us what your key takeaways for our audience should be for T-cell lymphoma in the Indian context?
Yeah. So Indian context, given the size of our country and number of lymphoma patients that we see, while the proportion of patient is only 10 to 15%, the absolute number is not small. So therefore, all practitioners should be aware of the presence of a T-cell lymphoma, its various manifestations, especially experts in the other field like gastroenterology, dermatology, and so on, and at all. The second point is that we have to have access to drugs at a reasonable price, and we have to have a data which we collate prospectively. Retrospective data comes with its limitation. It will give us a starting point, a benchmark figure. This is the outcomes retrospectively till now. I encourage that we develop data, we collate data prospectively for these atypical and rare tumors, and then see that where are the lacunae or areas of improvement. And that is the way we can go forward, join hand, and improve outcome of our patients who suffer from T-cell lymphoma.
Well, I wish to thank you very much for this very enlightening discussion. And I hope that I can turn to you in the future for more discussions along topics in malignant hematology. I really wish to thank you very much.
Thank you very much, Dr. Vish, for conversation as well as for highlighting this point. I will be very happy to contribute scientifically wherever it is possible. And maybe whenever we speak next, I might be armed with some Indian data to show, and we can discuss over that.
I look forward to it. Thank you.